My name is Marie McPherson, and I'm at the Center for Behavioral Health Improvement and Solution. And we're very, very happy today to have to introduce to you the child and adolescent psychiatrist at the University of South Florida Department of Psychiatry, who will we're going to introduce each one of them. They'll tell you a little bit each one of them where they went to. Where their experience and where they went to medical school, and then how long have they been practicing psychiatrist, and their experience with the hotline. The Behavioral Health Collaborative Pediatric Hotline is funded by Children's Medical Services of Florida. And we've been around for about 8 years or so. And this is very dear to my heart to have this pediatric hotline available to pediatricians and all primary care pediatricians, because as you know, it's been very difficult in the pediatric environment. They're more and more increasingly called on to treat children with behavioral health crisis and issues. So it's a good resource to have, to be able to call a psychiatrist, have some kind of a, it's the electronic hallway consult, so to speak. So without further ado, I would like to introduce each of our psychiatrists, and we're going to start with Dr. Stock. You have the floor.
All right. Hello, everybody. I'm Dr. Saundra Stock. I went to residency here at the University of South Florida and did my child and adolescent psychiatry fellowship out in Seattle, Washington at the University of Washington. I've been faculty here at USF since August of 2000, so 22 years. And during that time, I've served in a variety of roles, but I was the program director for the Child and Adolescent Psychiatry Fellowship for 18 years. And I served on the American Academy of Child and Adolescent Psychiatry has a committee that writes the practice guidelines for child and adolescent psychiatrists. And I was on that practice guideline writing committee for almost 20 years, starting in 1999. And so have lots of experience. Most of my work these days is outpatient. I did run a child and adolescent inpatient unit for a year. And then most times I've been seeing patients since about 2004, mostly just outpatients, seeing patients in clinic, seeing, consults outpatient sometimes, occasionally consults in the hospital. So I've had a wide variety of experience, over the years, and, happy to, answer people's questions. I know that access to child and adolescent psychiatry is very difficult depending on the area that you live in, and it's certainly difficult even in the large metropolitan areas, and difficult for some families based on their insurance and things like that. So we're more than happy to talk to pediatricians, delighted to do so, to try to help pediatricians who are kind of always, the fallback for families. Really the pediatricians are always the medical home for patients, and end up dealing with crises in between when patients aren't able to access care for one reason or another. Either they haven't gotten in, or they've moved, or their insurance has changed, or something like that. I know that all kinds of complicated cases, even if patients have had insurance and have seen a psychiatrist or seen a psychologist or been in therapy, they may end up back with pediatrician with questions in various transitions in their life. So I'm really happy that we've been able to participate, that USF's being able to participate with this grant, and being able to, offer services to pediatricians to be able to answer questions when folks have them. So.
And I may mention by Dr. Stock has been a faithful and active participant in Florida guidelines as well for child and adolescent psychotherapeutic medication, and we're very grateful for participation as well. Thank you so much. So now we will have Dr. Kalibi. Please, we'd love to hear about your background.
All righty. So my name is Christopher Kalibi, and I did my general psychiatry training in UMDNJ, which is now Rutgers, in Newark, New Jersey. So Did that there. Then I moved to New Orleans to do child psychiatry and forensic psychiatry at LSU in New Orleans. And then I was on staff at LSU Medical Center in New Orleans for 11 years. And during that time, I split between juvenile corrections and working in primary care clinics. So I did half time at the various juvenile corrections institutes, but half the time I did mostly initially was I worked at a federally qualified health center, and I was kind of co-located there, but it was a standard community child psychiatry practice. And then after my last 5 years or so at LSU, we got a collaborative care grant, and I was co-located in different pediatric clinics around Louisiana, sometimes on site if they were close enough to New Orleans, and doing a lot of tele-psychiatry and doing a lot of like consultation. So, I think it's a great model that there's so few of us and there's so many patients, and obviously it's great to organize these systems so we can support people out in the community. It makes much more sense. We can only see so many people at a time. This is a great project, and I'm very happy to be involved, and, we look forward to continuing, to assist.
Thank you very much. And if anyone has a question, please feel free to pipe in. Meanwhile, thank you, Dr.
When did you join USF? I'm sorry. You talked about LSU. When did you join USF?
Oh, I came in 2016. So yeah, I was in New Orleans from 2002 to 2016, and then I came to USF in 2016, and here I am.
Great. Thank you so much, Dr. Kalibi. Now, Dr. Fallon, please tell us about you.
All right. Hey, everybody. I'm Daniel Fallon. I did my residency training and child psychiatry training in a combined program at the University of Massachusetts in Worcester, Massachusetts. So I did a five-year combined program there, which was great, and similar to what Dr. Kalibi mentioned. I was fortunate as part of my fellowship to take part in what's the Massachusetts Collaborative Child Psychiatry program with Pediatrics. It's called MCPAP. So as a fellow, I was able to work in a collaborative consultation model for pediatricians in Massachusetts, along with my attending psychiatrists, and then the fellows would get to go to pediatrician's offices. So I was in all of my second year co-located in a pediatrician's office for a half day a week for a good bit of the year, and enjoyed working in that setting. I finished my training at UMass in 2011 and then joined on faculty, and so I've been here at USF since then. I've been working primarily doing graduate medical education, as I am the program director for the general psychiatry residency program. But when I'm not doing that, the rest of the time I do child and adolescent psychiatry outpatient in our outpatient clinic, and then a little bit of child and adolescent psychiatry clinical trials as well. So those are sort of the three things that I do. So far I've definitely enjoyed joining our faculty and serving with answering the phone calls and doing the consults. It's been an enjoyable experience for me to work with our pediatricians all over the state. It's been kind of nice to kind of hear from folks all over the state.
Okay, all right. So thank you so much, Dr. Fallon. And I also mentioned, I mentioned it before, but I'll do it again. We're very fortunate to have Dr. Fallon who can do consult and answer over hotline in Spanish. So that's really an added benefit for us. Okay, all right. Then Dr. Ruth.
Hi, good morning. Well, good afternoon now. I am Dr. Lee Ruth. I graduated medical school in Los Angeles at the University of Southern California, then decided to leave Los Angeles and leave the traffic behind and moved to Baltimore, Maryland, where I did my residency and CAP fellowship. at the University of Maryland Shepherd Pratt training program. And from there, I graduated and joined USF with Dr. Stock, Dr. Fallon, Dr. Kalibi, and Dr. Yanouzi in 2017. So I've been on faculty now for 5 years, and I just took over from Dr. Stock as the program director for the CAP Fellowship program, and she's staying in her role to help me out as associate program director. So this was a career change for me to go into medicine. Before that, I was a political researcher in New Zealand, and then I taught English in middle school. So
Very interesting.
It's very nice to meet different pediatricians across Florida. I enjoy talking with folks, and I think it's a good collaboration that we can expand their comfort with treating mental health problems.
Thank you so much, Dr. Ruth, and our last psychiatrist, but certainly Dr. Gregory Iannuzzi. We're delighted to have you. I guess you're one of the latest addition to the Department of Psychiatry.
Indeed, fairly recent. I completed medical school at the University of Maryland in Baltimore, which is the same institution where Dr. Ruth did her residency and fellowship training. We did not overlap there, however. I came to the University of South Florida in 2016 for residency, and then stayed and completed child and adolescent psychiatry fellowship here, followed by a forensic psychiatry fellowship here. And I joined the faculty in August 1st. So we're coming up on 5 weeks.
Oh,
but
okay.
It's great to be a part of this and to have the opportunity to extend good mental health care to places that may not otherwise have access to child and adolescent psychiatrists and folks with our training here.
Great, thank you so much. So as mentioned before, it's a terrific resource for our primary care pediatrician. And right now I would love to hear about one of our pediatricians who had an interaction with the hotline. Dr. Robinson, have you tried a hotline yet?
I've probably met most of you. I'm in Tallahassee. I'm an adolescent medicine physician. Sadly, the only one between Pensacola and Tampa, perhaps, who's active. So I see a lot of adolescent behavior problems because if you're a male in adolescent medicine, you do mostly behavior. If you're a female, you can split it between behavior and gynecology. So I do mostly behavior, so I consider myself a C-rated psychiatrist who can do pap smears. And that's about my story, I guess. Treat a lot of eating disorders, of course. And I appreciate all of your help. Many times y'all have helped me.
So we even hear that you're being chased down for returning calls.
I'm sorry?
You're being chased down by, if you do not answer the call right away, but you're being called back, you will be chased down.
Yeah, Dr. Stock, well, all of you have been great about that. I've been really busy. I've been kind of covered up. I was just looking, I think 5 of the last 6 weekends, I've been in the hospital with eating disorder patients. It's been really busy. They've just come out of the woodwork. It had been 4 or 5 months before that I'd had an eating disorder patient in the hospital. So I don't know what's going on. So sometimes my phone doesn't pick up, or I'm actually in with a patient when you call. And y'all have been nice enough to leave your phone number so I can call you back, and I promise not to abuse that. I'd still try to call you through the hotline so y'all have some control.
Well, that is one of the benefits of a hotline. You will be, the hotline is being answered promptly, and we will try to call you back if you do not answer your phone, as Dr. Robinson experienced. So we will track you down, get your answers, your questions answered. One other thing I'd like to talk about as well is for our psychiatrists, what you just briefly, briefly said, what kind of question do you mostly encounter Is it question about diagnosis? Is it questions about medication management? Could you please tell us what sort of a question you encounter the most often? Yes,
Well,
Dr. Stock, will you please?
I would think that my experience has been mostly people have been asking treatment questions. Whether that's pretty often it's how to change medications. Somebody's on a medicine, how to taper off of one and start on to another. I think that's very common. Sometimes it's just medicine choice, period. What would, if I've tried these couple of medicines, what do I do next? And sometimes that relates to sometimes that ends up in a discussion about diagnosis, about a comorbidity that may or may not be there. But I would say most of them are around medication choice, tapering off of one and starting another one, I think is pretty common. And then occasionally some questions about just what other kind of resources let me think of, at what point do you look for residential treatment or something like that. So sometimes people are looking to get an idea, like what other levels of care are there available, or what kinds of things should they be thinking about. So I think most of it's treatment questions. We could certainly have some discussion about diagnostic issues, but I think most people have called us with a treatment question.
Anyone else?
May I? Yes. I totally agree with you, Dr. Stock. I'm Rosa Laos from Jacksonville. Definitely, this is an area that is very needed with psychiatry resources. Definitely with Dr. Fallon, we do have a significant number of patients that speak Spanish in our area. And when I call, unfortunately, after the pandemic started, actually, I thought you were not that active because I called before about patients, but after the pandemic started, I really, our group didn't really continue that much as before. Yes, one of the major things are, first, when I'm I wouldn't say pretty sure, but I'm, very familiar with the diagnosis of the patient. However, I want the input of the psychiatrist to make sure that I'm doing the right thing in order to start the appropriate medicine and not having side effects that can be more harmful than help. And also when I want to change to a different medication, that's another thing that I, want to talk with somebody and see how you guys can help me with the transition between one medicine and the other. And I love the booklets that you guys have. That's definitely I share with my colleagues here at Town Center in Pediatric Associates, Jacksonville.
Thank you so much, Dr. Hidalgo Laos. That's wonderful to hear that you found the pediatric hotline, being very helpful. So it's always gratifying to hear. Anyone else? So one of the questions that I had for psychiatrists, and we just heard that the questions are surrounding mostly around treatment, but are there situations where you've encountered some crisis? Was there to deal with a child in some kind of crisis, and have you encountered this type of a situation from a pediatrician calling the hotline? Anyone? No?
I would say that, sorry, go ahead, Dr. Ruth.
No, you go.
Yeah, I was going to say that I don't know that so much I've encountered someone in what I would necessarily consider like kind of an acute crisis where, I don't know, we were having to debate with the pediatrician on the call or the PCP on the call regarding, hospitalization or something like that. But certainly there's been some cases that I would consider very acute, meaning that like we're not very easy cases to manage, even for a trained psychiatrist in their office, if it was my own patient. I mean, really difficult, decisions regarding, making, having to make, pretty substantial medication changes and such. And so I think we've certainly I've seen some cases like that where, I would say, not so much a crisis, but certainly very acute.
Can we call you? Can we call you guys about that? I mean, I thought it was just basically to talk about, management. But if there is a crisis, we did have that here in Jacksonville. Yes.
I would like to respond to that. So I think it would not be appropriate to be calling this hotline for a crisis situation because it goes to a voicemail and then needs to be relayed to us. I think a crisis situation, you need to get the mobile crisis teams involved or send to an ER to activate, so that there's no time lost and potentially any issues that come up. But to dovetail on what Dr. Fallon was saying, I recently had a call that the patient was in an eating disorders treatment program, and they were calling to say, hey, what's the best thing for me to do when they get out? And so I think, that's an acute treatment they're getting right now, but they'd already, activated the crisis, and they were in treatment. So I think for crisis reasons, I think accessing your local services is very, very important to do. And then, go ahead, Dr.
Actually, I was just talking about, I'm sure, there are crises that have to be taken care of right away, for a patient to go to the ER. I'm talking about, for instance, a patient with ADHD, but also has depression and anxiety, nothing new, but medications may worsen actually the symptoms, and not necessarily they are going to go to the ER, but actually may have some worsening of the, especially anxiety. That kind of crisis, that is something that we need to do changes right away. I know you guys may not call us back right away because, your time, but within the next, maybe 48 hours, that's something that we can at least hold on the medicine and then talk to you and see what will be the best approach,
Right, absolutely.
I think so, Dr. Stock.
Yeah, absolutely. We, the hotline is available Monday through Friday, and we've got somebody covering each day. So, our hope would be that we're back to you the same day. Certainly within 24 hours, you wouldn't be waiting 48 hours, except like Friday somehow, if you were calling us right around 5 o'clock, that might be, I guess that potentially could fall through the cracks. But yeah, so if it's something where you feel like you can safely say to the family, I'm going to do a little bit of research and I'm going to call you back this afternoon with an answer, something like that, where it's you, like Dr. Fallon was saying, it's a little bit acute. You need to do something pretty soon to help this family avert an all-out crisis. But yeah, we just wouldn't want you to wait for us to call to decide if you're sending the person to the emergency room or something. I think if there's an immediate safety risk, the kid's acutely hitting somebody in your office or making threats or doing something, get them into a safe place. But then we're absolutely happy to talk to you about what's your next step? What are your next options? Once the kid comes out of the inpatient unit, what might you be thinking about? I mean, they may have put them on a medicine. Sometimes kids come out of the crisis unit and they're on a medicine and they're having side effects the next couple of days. And you're wondering okay, now what do I do? So we're more than happy to help you think through those kind of options, or what should we do when they come out of the hospital? What would be appropriate monitoring? Or like an eating disorder patient, like Dr. Ruth was talking about, what would be an appropriate level of how often do I want to see the kid to get a weight, and what kind of do they need to have a therapist, a nutritionist, or a pediatrician? Kind of what's the team going to look like when they're coming out of inpatient? So we're more than happy to help you guys brainstorm those kind of things.
Yeah, and I guess I would just recharacterize it as something acute rather than an actual crisis.
That's
perfect.
Right. And one more question,
also, psychiatrists could also recommend that you do schedule a tele-psychiatric consult, and then in which case, you will call us and we will schedule a tele-psychiatric consult for your patient. That's another option.
I was about to ask that. So your group, how do we do that? Also calling the hotline?
No, there is a number that you can call, and we'll be happy, Sabrina will be happy to send that out again, and then we'll be more than happy to schedule a tele-psychiatry consult, within a very, very short time frame.
Perfect. That's what I was going to ask. And is there any limitation with insurance?
No, the tele-psychiatry consult is open to children 0 to 21, regardless of insurance carriers. So it doesn't matter. It can be commercial insurance as well, or it can be Medicaid. It doesn't matter. So it's open to all.
Perfect.
Sabrina, this is Dr. Anzalone. I've been listening in here for the last 20 minutes or so I'm sorry to introduce myself. I'm at Healthcare Network in Collier County, Naples. I'm pediatric director here. My understanding was you had to have special setup for the telepsychiatry. So is this something that would be arranged? I'm sorry if I missed this piece, arranged with the patient and from their home. So, or do they have to be on site? Exactly what is it like?
Well, right now the tele-psychiatry consult, is done is on site from the pediatrician's office, because at this point I think it's very important for the pediatrician to be there as well, and to be able to talk to the to be able to communicate with the parents, and after in regarding the treatment, and have a thorough discussion with the psychiatrist once the consult is over. So yes, we're very happy to set that up for you, and it's quite, the technology is so simple that it shouldn't be an issue. So have you had experience with the hotline?
With the hotline, yeah, absolutely. I've spoken to Dr. Stock a couple of times. Actually, some of my colleagues from the other offices as well all had positive experiences, all related to medical management mostly, as she described earlier.
Excellent, excellent. That sounds good. I'm glad to hear it. We're very, very interested in being able to keep this program up, but I think it's very much dependent on how useful the primary care pediatrician community finds it. So we certainly want to hear from you often, absolutely.
Yeah.
As often as possible. And it's been for those who have used the service, they found it extremely helpful and useful. So so please continue to help us in keeping the service up, because its use right now is shall we say low.
Yeah, I'm sure.
So we're trying to increase its usage. I think it's a terrific program. It's free, and you have access to very experienced psychiatrists, and are very willing to help you out with all your various issues. Dr. Chess, it looks like you have a question. Can you put your mic on?
Right there?
Yes, perfect.
Okay. Hey, guys, thank you so much for your willingness to help us out. I had never used the service. I've been hearing about the service for a long time. And I guess I just have my question is, so I guess you, in addition to having the service available to the practitioner, like for me, the pediatrician, for any case that is maybe a little difficult that we want to chat about and present you the case, you also can do from the office a teleconsult, like I can have the patient at the office and at that time generate a consult in my presence. Is that what I'm hearing? That also that is a duality, is also a way to perform this type of service?
Yes, and we'll be very, very happy to set that up for you. Again, it's also a free service, and absolutely, Sabrina will contact you and we'll set that up. And if it's when you do have a need, or a child who you feel could use some mental health psychiatry, and then we will be very happy to set that up. And put you in contact with one of our psychiatrists, and the waiting line is, you know, we can set you up with an appointment within 24, 48 hours. So it's very, very fast. You won't have to wait for 6 months. Let's put it this way.
Okay, that sounds great because, you know, that's pretty much what I get stuck, you know. We have psychiatry, as you know, the mental health service is very limited in terms of the availability. And that would be great. I think that you're probably going to hear from me because that's where I particular myself get stuck. You know, I have those difficult cases that, you know, I can just bring as a consult, and actually being present in the consult, it helped me because I get to know the family, because I find out that sometimes they tell you more than they tell me. It's like when I read the report, when I send it to the specialist, like, I don't remember she told me that, and I asked that, you know. So that's really a great feature. A last question that I have, and I'm sorry, I didn't mean to. So how did that work? So you guys don't charge the insurance, or do you charge the? Do you have a code for charging insurance? How did that work? Because since I'm gonna spend like a time, I know you're gonna see the patient, but that also require more time for me. Do you, if you don't charge, I mean, do we, and I guess that goes for the other pediatrician, do you guys have is there a code for that as a consultation? I mean, I feel funny not to, charging in a sense, because it's kind of educational to me and helping the patient, but I'm also using my time.
Right.
What is your experience with that?
So I don't actually know what all the pediatricians do. I would say that a number of pediatricians where I've seen patients with telehealth for an actual consult. So like if you call the pediatric hotline, you would talk to us for 10 or 15 minutes, and if we decided you should get a consult set up, then we would you get that set up when the patient could come in, and that would be a separate time. So yeah, those are usually we're with the family for about an hour. Marie is able to set this up, and this is all funded through a grant with the state of Florida. So most of the pediatricians, are seeing other patients while we see their patient and talk with the patient and family, and then the pediatrician comes back and we discuss the case for a few minutes, give our impressions, give our plan. If you chose to sit in the room the whole time with your patient through the whole consult, I think you could probably bill for you could bill their insurance for your time, because you're using a 99215 if you wanted to bill 9215 based on time, because you're, like you said, you're using your time. We are not billing their insurance, so you would be free to do that if you chose to sit in the whole time. But most people just sort of arrange it where they come in and speak to us on the video after we've seen the family, in between patients.
Oh, well, thank you.
Right.
Ms. Dr. Angela, I want a question about documentation. It's on your system. For a patient, for instance, we have Athena in our office. We would book it through Athena. Patient would be like a dual visit. It would be probably something like where the telemedicine would happen with your material, your hardwired or whatever computer that you have to be able to access the telemedicine. Then the discussion for diagnosis and treatment might be documented in our EHR, and I guess in that case, our total time spent can be billed accordingly using the codes appropriate for time that's spent. That might be a way to work around that. I'm not sure if anyone else has done that. I've not done the tele-psychiatry, but that's how I envision something like this to work for the billing side. Do you have any comments regarding that, or anybody have experience?
I mean, absolutely. You could do that too. Like if you chose, sometimes the pediatrician comes in and sits with the family, and I'm giving all of them my recommendations, or I've already usually talked about it with the family, seeing what they feel comfortable with. And then some people send the patient out. I think that might be harder to bill, but if you were sitting with the family and chose to hear the feedback altogether, you can certainly bill. It depends on your billing, your interpretation in your system for billing, whether or not you need the family actually in the room with you. But certainly if you were receiving the feedback and the family was in the room, you could bill that as a E&M code. And there may be other codes that you could use just talking with us.
And we'd be happy to send you the codes as well.
Yeah. And I think complexity of diagnosis, if you have major depression, it's going to be possibly a 4. If it's ADHD, it's a 3. You figure out basically complexity, medical complexity can be the other way to do that. And with the treatment plan, obviously the prescription's written. That's the physicians becoming more astute on coding. But I think that that's probably going to be the way it's going to go down. Unless you have any other ideas, I'd certainly be open to it.
Now, I think it's only fair that you are scheduling the patient, spending time with the patient, and the patient then goes through the consult, and then after that, there is you spending your time discussing with the psychiatrist, what the best approach to the treatment plan. So definitely you should be compensated for that, for the time you spend doing that. And we have several codes that we will be happy to send you where, you can bill for your time spent with the patient and mental and behavioral health consult. Absolutely. It's very acceptable these days.
Now in pediatrics, we'll be looking at kids with ADHD, depression. It's usually based on time. So it's usually a 3 or 4, or mostly 3s and 4s because of complexity. So medical complexity is probably the key. And I think time spent reviewing records, time spent, consulting like on the phone is also included. So time management is really critical to the other physician point. How much time you're spending can be documented. And as long as you document what you do and that you spend time reviewing records, especially if there's a consult. Are we going to get a copy of the consult that you do, or how does that work? The telepsychiatry consult, will there be like a formal faxing of your consult to us?
Absolutely.
Okay. Well,
absolutely.
So we'll have documentation that a consult took place. I think it's golden. I don't think it's going to be very complicated.
And actually, I think a 99215 would end up being on the day of service if you take into account all the elements for the day of service between checking the patient in, talking with us, debriefing it all with the patient, sending in the prescription. It's going to be a 215.
Complexity plus time. Yeah, I think that's awesome.
Excellent.
Can I follow up on a question?
Sure.
In that regards, how do you actually send us the consult if there is an official consultation?
Sabrina, we send the consult. We fax the consult notes to you. Correct, Sabrina?
We can fax them or send them via secure email.
Yes, that's what I was thinking about. No, so okay.
So there is follow up, and there is and actually it's like 3 or 4 pages. All the time that you spent with the patient, and that your impressions and your in other words, the consult notes, and with the treatment recommendations as well. So yes, it's very complete, and it's certainly very informative. So has anyone any other questions?
I do. I'm sorry.
Right.
The other question, if you allow me, one is that when we call the hotline, I like this feature that I can see the person, the face and that interaction. When you call the hotline, is only over the phone. Like if you have a case that you want some adjustment medication, some advice on some management or some side effect that you want to discuss, can you do like a FaceTime or just over the phone?
Well,
I wouldn't mind doing FaceTime. That would be fine. I think it would be up to the individual psychiatrist. If you have iPhones, it's easy. We can FaceTime each other, or you could set up something in Teams, or I don't know how to set up Zoom, but yeah, so I think that would be fine.
Okay. And the second question is that as a pediatrician, I know we are pretty much acting more like a resident or a fellow. Is there any particular presentation when we have a case, the documentation that you want us to have? Because I know you guys are doing this and great, but your time is very valuable too. Is there any way that we have like a format or the things that you want me to tell you? In that way, we don't have to go, with so much information that you don't need it. And we can kind of streamline the information so it's beneficial to all of us. Do you have anything like that?
Yes. So Sabrina, can you tell Dr. Chase? Sabrina? Well, yes, we do. We do. Like we send you we call it a referral form, and then you give us a little bit of you will give a psychiatrist an idea about what the issue that you would like to discuss and what sort of a presentation do you see. So yes, it's a prerequisite for the setting up the consult.
Okay, thank you.
And I think one of the most important things I've been finding is to really know what the previous medication trials are, so that I'm not trying to recreate the wheel that you've already spun, that we can be the most helpful if we know what you've already tried for the patient.
Okay, thank you.
Dr. Stock, Dr. Stock speaking. I think I recognize the voice. Is that Dr. Stock speaking?
Oh, sorry, that was Dr. Ruth.
Okay. So one of the advantages we have here at Healthcare Network is we have behavioral health, so integrated within our practices. So mine is Keenan Tam. He's a clinical psychologist. So what I would envision is he being present in the room and having everything that he needed from the standpoint of the dynamics of workup and evaluations and diagnostics that we've performed in the office. And that might be really, truly helpful and really get really more bang for our buck by having our behavioral health. And they could probably build the behavioral health codes and I can build the medical codes, and that would work out. My question is, since this is sort of like having it's like having a consult, having virtually consult a patient, obviously present in our office on site, not in their home. There's this big question about credentialing, providers, whether they can work within a facility, because we're an FQHC, so it's a little different feel for than just private practice. So I'm wondering if that really even needs to happen, because you're really operating on your own at a distance. We're consulting you separate from us. We're not billing for your services. You're using the grant for your services. We're billing for our time for our medical management and maybe my behavioral health for their involvement in the treatment of the patient at the time of the visit. It's sort of like having three people here. We have the doc, we have the psychologist, and we have the psychiatrist. So do you see that? I mean, I'm just trying to get away from the idea of having to be credentialed. What are your thoughts about that? I mean, has that been discussed?
Yes, that has been discussed at length, actually. And but since our psychiatrists are not prescribing any medication, the treatment is totally under your control.
Right.
So, do you agree with that, Dr. Stock, Dr. Fallon, Dr. Kalibi, and Dr. Anusi, that, our psychiatrists are not the one prescribing?
Right.
Right. The difficulty is that this is a little bit of a different technicality, that some sites require, like federally funded sites require credentialing for anybody to interact with their patient. Like it's just like if we were coming, federally funded sites, some of them view it the same as if I was walking onto your property and coming into an office and seeing one of your patients. So I'm interacting with one of your patients, you are giving me information. So some sites, some of the lawyers interpret that as needing to be credentialed at your site. So I'd say most sites where you don't have to get credentialed at, when it's most of the smaller practices, we don't do credentialing. It's just the larger systems where that becomes a question. Right. And if we didn't have to do it, we would love not to, because it's a lot of paperwork and fingerprinting for us and all that.
So what is the let me ask you this. So I obviously want the physician there to talk to them. Is there a problem with having it done at the patient's home and not at the site, and then having a second conversation as a curbside consult with the physician to be able to do the med management? I mean, I'm just trying to figure out how to get around.
We have not tried that. We have not done that to have the patient do it from the patient's home. There has, we've heard it's not always easy. The patient is, all of a sudden is not available, is not forgot, or they're not at the same phone number from one day to the next. That's why, being on site is sort of ensure that the patient will show up and there will be a sort of a better type of discussion, or would take it a little bit more seriously. Right. So that's one of the reasons done on site in the pediatrician's office?
We've been, thank God for telemedicine because it bailed us out during COVID. But I can tell you, the no-show rate in telemedicine is somewhere around 2% from what we've been experienced. And with even behavioral health, I schedule anywhere between 9 to 10 in the evenings, and I'll get almost 100% every time. So I think maybe it's a manifestation of the type of population you deal with and how much is done in advance to set up the appointment. But I think you may have, depending on the situation, may have great success if we set it up properly with the, obviously the intent of making it important that they attend and confirm, et cetera. I'll do all the background stuff. That might work.
If I may interject, there is a bit of a safety concern too. There's been times where I have had the pediatrician, send the child on a Baker Act based on what they've told me in the office, and it would be more difficult to do that when they're home alone and I'm not their physician. So that's one of the things.
I would never put my colleagues at that kind of if they're Baker Act, then you're not getting a tele-psychiatry appointment. I mean,
you don't always know though. Honestly, you don't always know what it is the kid is going to tell or disclose.
Yeah, I got you. If that happens at home, that's a great point. That but ADHD management, ODD, maybe the depressions, etc. I don't know. I make it happen without going through too many hoops.
Yeah, it's something we could explore. You still never quite know because the kid can get very angry. A kid can storm off a little more easily at home. We also have to make sure we coordinated seeing the patient at home. There's connectivity issues sometimes with people's Wi-Fi if they're rural. And then making sure that once we've seen them, we can get in touch with the pediatrician quickly. It's sort of like when they come to your office, the pediatrician like knows, oh yeah, this family's here. I'm going to talk to the psychiatrist in an hour. Versus, I think you could lose sight of that a little bit more, and then we could have trouble connecting the providers. But it's not a bad thought. We could think about whether or not going forward that would be feasible, because we do want usually current vitals. We want the blood pressure, height, weight. We need to talk to the pediatrician. So it just has seemed better for most places for the family to carve out time to come where they don't have dogs barking and other kind of distractions. So they're there and they're focused.
Yeah, I hear you. I've done a few telemedicine visits where that's happened. Yeah, in the evenings. Yeah, but we don't have blood pressures. We don't have heights and weights. I do evening appointments for ADHD med checks and follow-ups and make sure patients are doing well on their meds. Especially so they're not missing school. I usually do one in the office, then maybe 3 months later at tele and back and forth. But so you do get to see them face to face. But those are things that I'm just thinking from the standpoint from what I've experienced doing behavioral health through telemedicine at home. That it's been very successful. It's tremendously successful, actually.
Perhaps as a follow-up, with the patient as a second visit, but perhaps it's perhaps wiser to for the psychiatrist to do a first visit inside, on site in the office with the pediatrician present, and perhaps, as a follow-up and to start with less complicated cases, perhaps.
Yeah, I think so. I mean, I would this is going to be exciting. I'm just hoping we can work it out.
I hope so too. That's fantastic. I know we're running out of time, but I just want to thank our guests, our callers, and definitely our psychiatrists for so generously spending their time with us and taking the time to meet with you. And now that you can see the faces, that you'll be more comfortable in calling. By the way, this is recorded and will be put on our website, so you can feel free to watch this webinar, time and time again. Thank you so much, everyone. I really do appreciate all your help and contributions.